Welcome Dr. J.P. Clancy, Senior Vice President for Clinical Research at the Cystic Fibrosis Foundation.
It was him, not me. Man, what a great audience. It's so good to see everybody. What did you guys think about that first plenary yesterday? Woo! Nailed it. Absolutely nailed it. Well, it's so good to see everybody, and good afternoon, and welcome to everyone here in attendance and online to the second plenary session of the 2023 North American CF Conference. Yesterday's plenary gave us a glimpse into what can be accomplished with gene therapy in sickle cell disease, and it helps us see a future that may be in front of us for CF. Before I introduce the second plenary, I would first like to bring my dear friend and colleague, Steve and Rowe, to come to the stage. As you probably know, Steve joined the CF Foundation in 2022. He's the Chief Scientific Officer who's helping drive the next generation of therapeutics for people with CF. Today, Steve has the privilege of presenting the CF Foundation's top honor for researchers. Please welcome my dear friend, Stephen Rowe.
Great, well, hello. One of the most rewarding parts of the North American CF Conference for me is recognizing scientists who have dedicated their careers to advancing research to improve the lives of people with CF. This year, I have the honor of presenting the Dorothy Andersen and Paul de Sant'Agnese Distinguished Scientific Achievement Award, the highest recognition for research that is given by the Foundation to a person whose contributions to our scientific understanding of cystic fibrosis has been paramount in advancing life-changing therapies for people with CF. Originally named for Dr. de Sant'Agnese, the award was updated this year to recognize the legacy of Dr. Dorothy Andersen. Very good, who is forever tied to the advancement in our understanding and how we treat and care for cystic fibrosis. Many of you know about the significant research contributions of Dr. de Sant'Agnese made to the field of CF. However, before Dr. de Sant'Agnese, there was Dr. Dorothy Andersen, who in 1938 discovered cystic fibrosis at what was then called Babies Hospital at Columbia Presbyterian Medical Center. Her publication and subsequent contributions to the field, including mentorship of Dr. de Sant'Agnese, sparked decades of scientific progress that has transformed the lives of thousands of people with CF across the globe. Dr. Andersen's foundational, lifelong work served as a springboard for others to progress our understanding of the disease, establish effective diagnostic tools, identify the underlying cause of, and develop treatments for cystic fibrosis. The mark she left is indelible, intrinsically linked to the work so many of you are doing today. We are immensely fortunate to have had so many exceptional scientists and clinicians contribute to CF over the years since Dr. Andersen's discovery, including today's honoree, who exemplifies the commitment both Dr. Andersen and Dr. de Sant'Agnese just demonstrated in the early days of CF. I'm pleased to announce that the Dr. Andersen and Dr. Sant'Agnese Distinguished Scientific Achievement Award is being presented to Dr. Robert Bridges for his foundational work in CF ion transport and physiology. His work was critical to the development and validation of CFTR modulators, including a number that remain in clinical development. Dr. Bridges received his undergraduate degree from the University of Houston before attending the University of Kentucky for his graduate studies in physiology, earning his master's and doctoral degrees. This was followed by postdoctoral fellowships at the University of Missouri and the University of Saarland in Hamburg, Germany. This training set the path to study ion transport and epithelial physiology throughout his career. In 1986, Dr. Bridges moved to the University of Alabama at Birmingham as faculty in the Department of Physiology and Biophysics, focusing his research program on sodium and chloride absorption across multiple epithelial tissues. With the cloning of CFTR in 1989, Dr. Bridges' research program move towards understanding the processes that regulate CFTR channel function. These studies continued across academic appointments at the University of Pittsburgh School of Medicine, where he rose to professor and vice chairman in the Department of Physiology and Cell Biology, and the Rosalind Franklin University of Medicine and Science, where he served as professor and chairman of the Department of Physiology and Biophysics and as director of the CF Drug Discovery Lab. Dr. Bridges' research has been pivotal to our understanding of CFTR channel function and its regulation. His research explored the fundamental processes that regulate ion transport in epithelial tissues, including the identification and use of small molecules that make up CFTR modulators to alter these processes. One of which has been essential to this drug discovery in CF in recent years and has been broadly used by academic and industry labs alike, including work on difficult-to-treat nonsense mutations in concert with the CFF laboratory and my own research group at the University of Alabama at Birmingham. This assay also lies at the heart of CFTR functional measurements essential for therapeutic, which has enabled the label expansion of modulator therapies for many more people with CF. Dr. Bridges has been a tireless advocate for rigorous academic science for almost 40 years, publishing over 100 peer-reviewed manuscripts and mentoring over 50 students and postdoctoral fellows, several of whom are in the audience today. For those fortunate enough to be near the front row, you might have even had a chance to experience the water gun from Bob's hands if your science was out of line, adding levity to the pursuit of rigor. Bob, we thank you for your commitment in CF, the foundation, and for all those we serve. This commitment from you and those close to you, your wife Diane and family, has informed our understanding of CF and helped provide the tools necessary to develop and distribute therapies for all people with CF. Congratulations on this award, and welcome to the stage.
Congratulations, Bob. So richly deserved. We've been so lucky to have you as part of our family for so long. Okay, y'all ready? You're in for a treat, I promise you. So it is now my great honor to introduce both the topic and the speakers for the second plenary. This year, the second plenary will focus on infection in CF, a topic that is consistently ranked among the highest priorities for people with CF. Furthermore, it's now 5 years since the CF Foundation announced the Infection Research Initiative, or IRI, a bold $100 million commitment to advance understanding and treatments for CF infections. The original IRI was developed in response to CF community input that identified infections as a central and common concern of CF children, adults, and care providers. The IRI priorities and guiding principles were co-produced in partnership with the CF community members, CF researchers, care providers, and CFF staff. As I reflect on what has been accomplished since the IRI began, I can't help but feel a great deal of optimism and a sense of real, substantial progress across so many fronts. Since the announcement of the IRI, over $140 million have been committed to address CF-related infections and their questions. This includes current funding of 18 different therapies that are in development, over 200 ongoing research projects, including 47 new projects in 2022 alone. Clearly, these efforts to advance diagnosis and treatment of infections in for people with CF has clearly not slowed down. But since the IRI began, CF infections have changed significantly, particularly post-pandemic, and with the availability of Trikafta for so many people with CF. As an example, 26% of people with CF cultured Pseudomonas in 2022, down significantly compared with pre-Trikafta detection. But importantly, even if the number of people with CF who have chronic infections may be declining, the need for those who are struggling with infection remains high. Therefore, we are thinking differently about how new antibiotics are being developed. And as examples, the CFF is supporting clinical trials of new treatments for Aspergillus in the transplant program population, and it's enrolling people who do and do not have CF. Additionally, the CF Foundation supports clinical research to treat NTM infections in people with and without CF. This approach enables trials to enroll faster, expediting the process and hopefully the development of new treatments that will benefit everyone, including people with CF. Today, we will have two extraordinary physician scientists discuss infections in CF, beginning with the microorganisms responsible for these infections, and then ending with clinical research and advancing how we can treat infections. To take us on this journey, I am delighted to introduce the two speakers for today's second plenary. The first is Dr. Luke Hoffman, an MD and PhD who is a pediatric pulmonologist, a professor of pediatrics, and an adjunct professor of microbiology at the University of Washington and at Seattle Children's Hospital. Dr. Hoffman received his medical and graduate degrees at the University of California at San Francisco. He completed both his residency in pediatrics and his postdoctoral fellowship at the University of Washington, where he joined the faculty in 2004. He currently serves as Vice Chair of Research for the Department of Pediatrics and Director of Scholarship for the Division of Pulmonary Medicine, Pulmonary and Sleep Medicine. He also directs a CF Foundation-funded National Resource Center for Microbiology that provides services, advice, and expertise in microbiology for CF for researchers and industry partners. Dr. Hoffman's research and clinical efforts for the past 20 years have focused on microbiology of people with CF, both in the respiratory tract and also in the gastrointestinal tract. Dr. Hoffman will then be joined by Dr. Natalie West, who is an assistant professor of medicine in the Division of Pulmonary and Critical Care Medicine at Johns Hopkins University. Dr. West received her BS and BA at the University of Florida, followed by medical school at the University of South Florida, residency at Vanderbilt, and then fellowship, followed by master's of health science at Johns Hopkins University, where she is currently faculty. Her research interests relevant to today's plenary include defining and treating CF pulmonary exacerbations. She is one of the lead investigators that has been integral in the design of 3 large multi-center trials examining treatment of pulmonary exacerbations, which she will highlight today. I cannot think of better qualified colleagues than Drs. Hoffman and West to take you on this journey. And between them, I can guarantee you that you will have a new appreciation and have new perspectives in this exciting progress in understanding and treating CF infections. So please join me in welcoming Dr. Hoffman to the stage.
I will. Thank you, everyone. JP, thank you for that fantastic, very generous introduction. I'm getting out the water now because it turns out it's dry here. I don't know if people knew that. I'd like to thank the foundation on behalf of myself and my co-presenter, Natalie West, for the honor of presenting to you today, and also to all of you for attending. And also all of you attending at home. Thank you for streaming in. And congratulations to Dr. Bridges. I do have a couple of disclosures related to the laboratory you just heard about, as well as my funding. What Natalie and I are going to try to do today is to give you a thumbnail sketch of what I consider to be a gigantic field. And so it's a little daunting. This is CF respiratory microbiology and respiratory infections. This field goes back over 80 years, since Dorothy Andersen first described respiratory infections as a big component of CF respiratory disease. And it's been served by a lot of really amazing scientists, and it's seen its share of breakthroughs. And I am afraid I'm going to grossly oversimplify a very rich field and shortchange a lot of people I admire. And so this is my pre-apology for doing just that. And I hope that people will continue to talk to me after this. Anybody who's been to a CF clinic or to one of our microbiology laboratories or just talked to me in the hallway has heard a lot of polysyllabic Latin as we talk about the bacteria and other microbes that infect people with CF. And so we've created some shorthand to talk about these bugs. So for example, we say the word Pseudomonas, We often say staph, or its subtype MRSA. We might say Burke, or its subtype Cepacia. Haemophilus is a word we use, as is steno and a chromobacter, and we often abbreviate NTM. These are just the bacteria that commonly infect people with CF, and of course there are plenty of fungi and viruses whose names we throw around as well. But for simplicity today, I'm just going to talk about the bacteria. And the reason we use the shorthand is right here. The names of each one of these, full Latin names, that is, of each one of these bacteria is a mouthful. And so for simplicity, again, I am just going to use the bolded parts of these words for the rest of the talk today. For example, on this slide, which is put out by the US CF Patient Registry every year. Many of you have probably seen it. These are data from just 1 year, 2022, and it shows you several organisms, and I've highlighted some of them, some of the ones that we care the most about or we talk the most about. It shows you the proportion of people with CF for 1 year, 2022, and the proportion of people is on the y-axis, whose respiratory cultures were positive for these pathogens or these bacteria, as broken down by age. So it's just 1 year of data, and you're looking at different prevalences in people of different, at different ages. And the reason that the Foundation collects information specifically on these organisms is that these are the bacteria that we usually refer to when we're diagnosing infections, and they're usually the targets of our treatments when we choose treatment. And this is because many of these bacteria are associated with worse disease. And so we generally call them pathogens, and this is a word that I'll use for the rest of the talk. We also use this kind of information to choose antibiotics when we feel that somebody clinically needs it, because we want to pick antibiotics that are likely to be effective or active against the bacteria people are infected with. And detecting different bacteria often triggers a different treatment response. For example, some pathogens like Pseudomonas aeruginosa trigger an effort to try to eradicate it, and that's not necessarily true for other bacteria. And finally, we use this kind of data, especially registry data, to follow CF microbiological epidemiology, so changes in the ecology in people with CF, as well as evidence of transmission or of outbreaks. This is another slide that's put out by the registry every year. Again, this is from 2022, but instead of just showing 1 year of data, they're showing 30 years of data on the x-axis there. Again, it's proportion of people, and this time it's all people with CF reported to the registry on the y-axis, and here are some of those organisms. I find this graph really interesting. I look at it all the time, in part because it's really tempting to map on big changes in the way we treat people with CF, such as the introduction of different antibiotics in the late 90s and early 2000s, and try to infer changes in microbiology that happened after that. Here's another event, or two different events that happened in recent years, the introduction of highly effective modulators. But there's another event that's important to map on here that underscores a really important point about looking at this graph. During the pandemic, fewer and fewer people made it to clinic to be sampled, and as I'll tell you in a minute, they also produced different types of samples. And so it's very hard to compare the data, or we have to be cautious in comparing the data after compared with before the pandemic began. And for more on how to carefully, cautiously judge and interpret registry data, I want to refer you to a really nice publication by Dutch Van Devanter, John Lipuma, and Mike Constant, which was published earlier this year. It's down at the bottom. We get all of these data, and the data we get in the CF clinic come from specimens. First, we collect specimens from our patients, and there are many different types we can get, but these are the three most common: oropharyngeal swabs, sputum, and bronchoalveolar lavage fluid. Of these, we love sputum. Sputum is, and don't quote me on that. We think sputum represents the best balance between convenience and lack of invasiveness, but also accuracy in reflecting the part of the body we want to measure, which is the lower airways. Regardless of the sample type, we then take it into the laboratory, culture it on artificial laboratory media. We let pathogens or other microbes grow up, and then we select isolates of those pathogens. We characterize them, and then we use that information to diagnose infections, and if we feel it's indicated, to choose treatments. These methods have been refined over 100 years, more than 100 years. They've been around a long time. We're very good at them, and they work quite well, but like all laboratory techniques, they have their pros and their cons. For example, some of these pathogens actually don't grow very well under these artificial conditions. Some of them, especially variants of some of these pathogens, actually take a very long time to grow. And both of these problems make it difficult to provide timely information, treatment information, to our treating physicians and to patients. Some of the tests we do, such as testing how antibiotics work in the test tube against these pathogens, don't seem to give us clinically useful information, at least not reliably. And increasingly, and I'll discuss this more in a minute, the kinds of samples that we're getting from our patients, mostly oropharyngeal swabs these days, don't necessarily reflect the part of the body that we're trying to study. And here's a workshop presentation on exactly this from yesterday. And by presenting or describing a workshop from yesterday, I'm not asking you to time travel. I'm suggesting that the abstract it would be interesting to many people here, and also referring you to the presentation if it's streaming in the future. A little bit more about this slow turnaround time we sometimes have from the clinical laboratory, and also some emerging techniques to try to address that. There are techniques on the horizon that we actually use in research that don't require us actually to culture bacteria from a sample, but instead we use their DNA. We extract the DNA from a sample, and then we can use polymerase chain reaction, for example, to identify and enumerate specific pathogens from these samples. Luckily for me, and I'm sorry about this, everybody here has heard of PCR a lot over the past 3 years, so I don't need to describe it, but just importantly, know that we can adapt PCR to identify and quantify almost any pathogen out there. But we don't just have to identify one pathogen at a time. We can also take all of that DNA and sequence it. We can do next generation sequencing. And at least above a certain threshold, we can then quantify, identify almost all the microbes that are in a sample. And that is called a microbiome method or a microbiota method. You may have heard of these. Neither PCR nor microbiome methods or sequencing are in routine standard use in the clinical laboratory, but they do show some promise in trying to improve our turnaround time and maybe some other features. For now, they're mostly used in research. And together, culture-based techniques and DNA-based techniques have taught us a tremendous amount about CF respiratory infections over the 80 years since Dr. Andersen first described them. And I'm now going to, again, grossly oversimplify a very rich field. I'm going to give you just a few concepts that we've come up with over the past 80 years. Here's one. We know that microbes adapt to their environment when they infect. That is, they mutate so that they can thrive. And in CF, the characteristics that these microbes are adapting to are contents of mucus, which is where these infections are localized, elements of the immune system, gradients in oxygen and nutrients and other gases, and the many medicines our patients take, especially antibiotics, but others as well as other microbes, which are often also there, and microbes interact with each other. However, this concept that bacteria or microbes infect and then mutate in a very stereotypical way in one direction turns out to be an oversimplification, because we now know that microbes, such as one bacterium, one cell might infect and then diversify. It mutates in many different ways, and you end up with populations of very diverse bacteria. And they can differ, those progeny cells can differ in terms of antibiotic resistance, how fast they grow, how pathogenic they are to the airway and other tissues, and many, many other characteristics. So and by the way, this kind of diversity was exactly the topic that you're going to see in the symposium that's going to be right after this session, which I hope to attend. It turns out, of course, because everything in CF is more complex than we think it is, that even this view is an oversimplification. Because bacteria don't just diversify and then distribute homogeneously throughout the lungs. We have good evidence that these bacteria compartmentalize. That is, you get different populations in different parts of the lungs. And I think one of the best pieces of evidence, the strongest one, came from several years ago from Peter Jorth and Pradeep Singh, and they've followed up on this since, where they followed populations of key CF pathogens, Pseudomonas aeruginosa, in explanted lungs from people with CF, and found evidence that Pseudomonas distributes throughout the lungs, and then those populations become isolated and diversify in place. So you get different populations of this one bacterium in different parts of the lung. And this may help us to understand the patchy nature of CF disease as well as the patchy or regional nature of response to antibiotics. And we just heard this morning from Sam Durfee about an amazing update to this study. Speaking of antibiotics, I think everyone here likely knows that these have been critical in our fight against CF lung disease for more than 80 years. But just like every treatment, they have their upsides and downsides as well. And I'm going to try to make the case in the next 10 minutes that this is a great time for us to continually reevaluate these trade-offs as treatments improve and patients improve with them. And you're going to hear from Dr. West in a few minutes about some of the ongoing and upcoming studies that are reevaluating these trade-offs. But I'm going to try to set things up by describing what those trade-offs are. Among the positives, antibiotics are very helpful for eradicating some pathogens after we detect them. When early after detection is when we think they're easiest to eradicate. Even after pathogens establish chronic infections, we can still use antibiotics to suppress them as a maintenance medication, and antibiotics play a very important role in helping some people recover from increases in symptoms called respiratory exacerbations, which again, you're going to hear more about in a minute. On the downsides, however, these treatments can select for resistance, they can cause organ damage and toxicity, and they can disrupt bacteria in other parts of the body that we don't intend to hit. That's off-target effects. Just a minute. So the CF community is very aware of these downsides and quite concerned about them, as shown in a recent priority setting document by the James Lind Alliance. This is a nonprofit UK priority setting organization who in 2022, most recently, sent a questionnaire out to many CF patients and their caretakers asking what their priorities were for improving their lives and care. And number 5 on the top 20 list of priorities was reducing the negative effects of antibiotics. And in particular, people with CF are concerned about antibiotic resistance, and understandably so. This was actually the topic of a wonderful symposium yesterday. Many of the talks were about trying to sidestep antibiotic resistance. But it was also the topic of a really inspiring testimony by an adult with CF named Melanie Lawrence earlier this year, who, on behalf of the CF Foundation and actually on behalf of all of us, testified to a Senate subcommittee about the importance of antimicrobial resistance. And I want you to watch her own words.
My story is not an uncommon experience in the CF community, nor is it unique to people with CF. Bacteria are abundant, and it is inevitable that more Americans will encounter resistant infections. It is not a question of if you can catch them, it is a question of when.
I know you join me in thanking Melanie for joining the fight. I want to talk a little bit about these off-target, thank you, yeah, please. I want to talk a little bit about these off-target effects, which we don't think about quite as often, at least we haven't so far, and that's the effects of antibiotics on bacteria we don't intend to target. We know it happens. For example, from this study that was from my own laboratory by a very talented scientist named Maria Nelson, she collected sputum samples from 30 adults with CF and defined the microbiota in the sputum before and after starting on a month-long round of inhaled tobramycin. This is a maintenance antibiotic used by many people with CF. On this two-dimensional graph, the locations of each one of those small dots represent the microbiota in one sputum sample, same patients before and after tobramycin. And the distance between those dots represents differences in the microbiota. The big dots represent the averages for each time point. So I think it's evident that there are big changes in sputum microbiota after starting on inhaled tobramycin. But Maria went on to show that the biggest changes were not in the abundances of the pathogens that I've been talking about, but actually in a lot of bacteria we don't intend to target, many of which usually just live in the nose and the mouth. And we don't yet know the consequences of those off-target effects. More recently, D.B. Sanders at Indiana University collected oropharyngeal swabs as a proxy of the respiratory tract and fecal samples as a proxy of the GI tract from infants with CF who are getting systemic therapy, antibiotics for a CF exacerbation. And he showed that the microbiota changed in both types of samples, that is in both spaces, about equally, but that the effects seemed to be longer lasting in the GI tract. And again, we really don't know what the consequences of these off-target, unintentional effects are, but I think we're very interested in finding out. So that's one problem facing the field right now that many of us are focusing on. Another is arguably a problem. People with CF are not producing our favorite kind of respiratory sample anymore very often. On one hand, this is great. It's great news. I think people with CF are very happy about it. It means that they're not producing as much mucus as they used to, and it's evidence of improvement. Here's some registry data, thank you to the registry for putting these together, that show this trend. You can see, again, proportion of cultures reported to the registry is on the y-axis, and what you see in the line here is the proportion of cultures that were sputum reported to the registry. And you can see that there was a decline evident even before the pandemic, and then that trend continued and accelerated afterwards. But again, we have to be very careful with those data because fewer samples were collected overall. And here's the reciprocal trend in oropharyngeal swabs, which have really replaced sputum. So again, on the one hand, we're very happy about this, but it does leave us with a bit of a problem. We don't yet know how to monitor these infections and choose treatments with this other type of sample type as often as we do. And again, this is a problem that's been recognized by the CF community and their concern because diagnosing lung infection without sputum was number 2 on the list of 20 priorities in this 2022 James Lind Alliance document. So this was also noticed by the CF Foundation, and they wisely assembled a workshop called Detection and Diagnosis that began a couple of years ago for exactly this problem. We quickly abbreviated it to D&D, which I am now representing with this incredibly nerdy reference. I am very glad to hear chuckles. It means there are people as nerdy as I am out there. Thank you. And I was very fortunate to co-chair this workshop with Lindsay Caverly, my colleague from the University of Michigan, and it was organized by these fantastic people at the CF Foundation. And we assembled a group of experts, and we talked about the challenges we're seeing with collecting spontaneously produced sputum in the clinic. And then we talked about some emerging approaches to try to deal with this problem or sidestep it. And here are a few. Gina Hong from the University of Pennsylvania, reviewing CF voice data that came from a questionnaire before, pointed out that actually if you just ask people with CF, they'll tell you they can produce sputum in the privacy of their own home, often during routine self-care, but not always. And if you ask them by questionnaire whether they're willing to send those samples into our microbiology laboratory, they're generally quite willing. And so this is one way that we might increase the yield or the proportion of people who can give us sputum. She talked about this, these updated data just yesterday. Julian Fortin gave us another opportunity or another example of how we might increase our yield of sputum through his aptly named the CF Spit study done in the UK, where they gave patients who were, the investigators gave patients who were showing up to clinic inhaled hypertonic saline, a common mucolytic and an airway irritant, and the resulting induced sputum had similar microbiological yield as some kinds of bronchoalveolar lavages. So again, this might increase the proportion of people we might get sputum from. But there are still likely to be people who cannot produce sputum, and for them, there were some really interesting and encouraging data from Jane Hill, Heather Bean, and Edith Samanik, who reminded us that exhaled breath is full of molecules, often from the microbes themselves, and these make great biomarker panels. Using advanced techniques that are not yet widely available to analyze these samples, they provided some really encouraging preliminary data that they can discriminate patients who do and don't have positive cultures for several pathogens, including Pseudomonas here, and we heard about non-tuberculous mycobacteria just yesterday. Another sputum-independent technique was reported by Steve Salaponte. It's called cell-free DNA, and he reported that you can actually detect the DNA of some infecting pathogens in the blood of people with CF, such as, for example, Pseudomonas aeruginosa. And the preliminary data he presented have now been published, as you can see, actually just the other day. These are data, again, showing good discriminatory power for people culture positive from negative with Pseudomonas aeruginosa, and he has data for other pathogens as well, so this is very encouraging. And here's another presentation on exactly this technique from just this morning. These techniques are going to be increasingly useful and important in the era of modulators. And that brings me to my final topics. I just wanted to review what we understand about how microbiology is changing in the CF community in the era of modulators from registry data and from research. And then I want to finish by just reviewing what we know about how microbiology is evolving in the very large proportion of people on this planet with CF who are not yet benefiting from these transformative therapies or therapies like them. So first, registry. I already gave you the punchline, I'm sorry. But because of the pandemic, unfortunately, we really can't infer from registry data, at least not accurately, what's happening to CF microbiology since triple therapy was introduced. So we have to turn to ongoing research. And in the United States, there are 2 parallel large observational studies, the PROMISE study in people older than 6, the BEGIN study in people between 0 and 6, and both of them are collecting a lot of different outcomes before and after starting on CFTR modulators, including respiratory microbiology and measures of lung disease to correlate them with. And there are parallel efforts in many countries. I'm just listing a few here that we're coordinating with so that we can compare notes. These are data from the population older than 12 in the PROMISE study. And actually this graph was shown last year in the plenary, and it's since been published by the respiratory sub-study PIs, Pradeep Singh and David Nichols. On the y-axis, you're looking at sputum density by culture of Pseudomonas aeruginosa, again, a key CF pathogen. The individual data, the individual population data, individual subject data are in black dots connected by black lines, collected before and then 1, 3, and 6 months after starting on triple therapy, and the average for the whole study population is in red. So I think you can see for Pseudomonas, and they've now shown for all pathogens that they've looked at, they are observing decreased average sputum densities of all pathogens, the standard pathogens I showed you at the beginning. And in fact, as you can see at month 1, many people have converted to culture negative. I should say several people have converted to culture negative for Pseudomonas and a number of other pathogens as well. However, for most people, these infections continued by several measures. They are maintained at lower levels. Interestingly, they did not observe a decrease in sputum abundance of non-pathogens, that is, the microbes that we don't consider to be pathogens, and we find this really interesting. The PIs have also reported preliminarily evidence that these effects are maintained over the 2.5 years of the study so far, and this is really encouraging. But this raises an interesting question. If the infections persist just at lower levels and people are healthier, how should we be thinking about these persistent infections in terms of treatment, our treatment and maintenance approaches? And these are 2 workshop presentations on exactly this type of topic just over the couple of days. I want to finish with this topic, remembering the very large proportion of people on the planet who are not yet on modulators or similar therapies, CFTR targeting therapy. And I put this graph here from the United States Patient Registry, again, to remind you of the prevalence of this key CF pathogen, Pseudomonas aeruginosa, relatively uncommon in children, and it reaches about 50% prevalence in adulthood, in people older than 34. So this is data from one relatively wealthy country, and I'm going to move on to Europe. Many of you, like me, may have had the good fortune of attending an absolutely amazing plenary by Professor Eitan Kerem at this year's European CF Society conference in Vienna, where he presented data, and I thank him for sharing these data with me. He couldn't be here today. He had worked with the European CF Society Patient Registry to categorize countries according to their gross national per capita income, at least for the year 2021, as a proxy for access to the most advanced CF care. And here are those categories. You can see that they categorize countries according to lower, middle, and higher thirds of gross per capita national income, and then restricted what I'm about to show you to this population with the same genotype. And they showed that the proportion of people in the countries that had the lowest gross per capita national income tended to have the highest prevalence of chronic Pseudomonas infection. And these differences were evident for every age group they studied. And as you can see, these gaps are not appearing to be closing. And this is just one example of the clinical effects of these gaps in care, seen through a microbiological lens. For more on the clinical effects of these gaps in care, I want to refer you to a really impactful editorial by John Paula and Terry Laguna published earlier this year. So at this point, I think many of us want to know in this field, how are these infections going to continue to change, whether people are on or not on modulators? How can we use our existing armamentarium of antibiotics in a more enlightened way? I think this is a really unique opportunity for us to really carefully look into this. And we all wonder whether there are more effective, no, equally effective at least, new antimicrobials, but that have fewer side effects. This is the work that's before us. This is the work that we're doing. And before you hear from Dr. West about how this work is being done, I want you to hear from a really powerful voice, another powerful voice, Nick Kelly, who's going to remind us why we're doing this work and for who. Thank you.
Hello, my name is Nick Kelly, and I am living with cystic fibrosis. The question everyone always wants to know, Nick, what's your Trikafta status? That's what I call it, Trikafta status. And mine, unfortunately, is negative. I am Trikafta single. However you want to put it, I am not eligible to take modulators. I was born March 16th, 1987, Team Pisces. I'm Cleveland, born and raised. I was an athlete in high school, all state in both wrestling and baseball. I then went to Bowling Green State University for college. I did my undergrad there, my master's there, and my internship there. I am a Falcon through and through. From there, I have been able to find multiple passions, the arts, nutrition, public speaking, and I am a person who truly believes passion is the most important thing you can have, so that's something I try to live with daily. I spend on average a third of my year in the hospital. And for the longest time, my average length of stay has been 31 days. CF has so many different forms of things that grow in your lungs, different bacteria, and everyone's a little different. So my primary one is called Pseudomonas, and it creates all the havoc it wants. It affects my everyday life. You know, I have to worry about feeling well, feeling bad, feeling a certain way each day. These infections really do play a huge part in every facet of my life. I am completely unable to work full-time, even if I wanted to. And that's saying a lot, because I'm a pretty active person. I'm kind of, I'm a go-getter, I'm up. I am now at the point where more and more antibiotics are not working for me, whether it be because the bug is resistant or because I'm having reactions to said meds. I've been raised to look up at the sky, hand held high. I'm waiting for that moment where I can fly. I'm stuck inside these four walls, and these walls are starting to shrink in. I'm starting to shrink in. Honey, Having a treatment option that could better fight my infections would be huge. Because with options becomes variability. With variability becomes progress, and with progress comes help. And that's ultimately what we're in need of, help. Everyone deserves a chance to be better, to be healthier, to extend their life, to have less symptoms, have less hospital stays. Everyone deserves a chance to be able to have that experience of increased health, increased hope, increased identity. Understand, I don't do it for the me, I do it for the we. Understand, I don't do it for the me, I do it for the we. One more time, just in case you didn't understand why I'm passionate and why I live. I don't do it for the me, I do it for the we. I am motivated by legacy. Each opportunity for me to challenge myself to go beyond what I thought I could do is an opportunity for me to build on the legacy that is Nick Kelly.
Thank you guys so much. I want to thank JP Clancy, Mike Boyle, and our colleagues at the CF Foundation for inviting both Luke and I up here. It has truly been an honor to talk to you guys today. And I also want to thank my family for supporting me here, who's in person today. Luke, you set us up so fantastically to continue our discussion today. And then lastly, Nick Kelly, I know that you're out there listening. Thank you for inviting us into your life with such honesty, and you're truly inspiring. So I received funding from the NIH and the CF Foundation. How will we treat CF infections on those on and off elexacaftor, tezacaftor, and ivacaftor? I'm calling it ETI for short from here on out. I remember sitting in this audience 4 years ago when ETI was approved. Our community was beyond excited to have a medication available for the majority of people with CF that dramatically improved lung function and symptoms. To understand CF infections even more, I want to get us all on the same page. What happens when infections get acutely worse? We call those pulmonary exacerbations. Exacerbations are associated with worsening symptoms, cough, shortness of breath, and sputum production, most of the time accompanied by a loss of lung function. We know they're associated with worse quality of life and even shortened survival. So what happens to a person with CF when they have an exacerbation? They're marching along, they're feeling okay, all of a sudden symptoms get dramatically worse, most of the time accompanied by a drop in lung function. And at this point, the CF team intervenes with antibiotics. We know that exacerbations occur frequently in the lives of our people with CF. And currently, they also are associated with worse outcomes that I just described. There is a wide variety in treatment practices across the world. We don't have much solid evidence in which to base guidelines upon. In 2009, the CF Foundation established the Pulmonary Exacerbation Working Group. This group of experts was tasked to tell us all how should we be treating our patients when they have an exacerbation. This group of experts could only agree on one issue. We should continue chronic therapies like airway clearance, pulmozyme, and hypertonic saline. But other issues we didn't really have much evidence on. How long should we be treating these exacerbations for? The site, whether home or hospital, was best, use of inhaled antibiotics and corticosteroids, and number and dosing of antibiotics. We knew we needed guidelines, but we had to get evidence in order to establish those guidelines. And so the STOP program was established. Standardized treatment of pulmonary exacerbations. There are over 70,000 people with CF worldwide. And it is our goal to build a house, a 70-square-foot house. While we know it would be great to establish one set of guidelines to fit every person with CF, we know that not one size fits all. We are looking to build 1 square foot for every person with CF. So what have we learned and where are we going? The STOP program has completed 2 clinical trials thus far, and we are currently enrolling in the 3rd. Over the next 10 minutes or so, I'm going to show you what we have accomplished. Patrick Flume and Chris Goss currently lead the STOP program, and I'm honored to talk about the STOP program and our progress thus far on behalf of my colleagues. I would like to say that none of what I'm about to show you could be possible without many of you investigators in the audience and many of you online that have already participated in the clinical trials. We thank you. So we're going to talk first about the observational trial. STOP-OB was a multi-center prospective trial at 11 centers from 2014 to 2015. We followed 220 adults who were admitted to the hospital. Antibiotic selection and duration were determined by the treating physician, and multiple points along the way, we captured lung function and symptoms, treatment patterns, as well as outcomes. And I'm going to show you some of the top-line results from this study. Out of the 220 adults, 43% had already had IV antibiotics in the previous 6 months. Half of our participants had failed outpatient antibiotic therapy, meaning we as a CF team had prescribed inhaled or oral antibiotics, and they still had to end up in the hospital. 2/3 of our patients had a dramatic drop in lung function, so 10% or more in FEV1% predicted. But interestingly, 17% actually came in above their baseline lung function. Symptoms were generally present between 1 and 3 weeks, but a third of our patients had symptoms for 3 weeks or more. And so what was lung function doing? On the x-axis, you're going to see time in days, and on the y-axis is lung function as measured in FEV1 change from the start of IV antibiotics. The average duration was about 13 to 14 days, so right around there, the FEV1 had improved by 9.4%, but you can see by day 28, had dipped a little bit. A striking finding of this clinical study was the patient's inability to recover back to their baseline lung function. And this echoes some of the work that D.B. Sanders had published just a few years previous to this. On the x-axis, you have proportion of baseline lung function that was recovered. And on the y-axis, you have percentage of STOP participants. So for instance, only 39% of these participants recovered 100% of their baseline lung function. Only 65% recovered 90%. This was the largest prospective trial to date of exacerbations, and we used the study to design STOP-2. But first, we actually surveyed you all, as well as people with CF and their families. Many of you that answered the survey are here in the audience and online. Your voice was heard. When we asked you, which question did you want us to answer first? The answer we heard over and over again was duration. How long should we be treating these exacerbations for? So we used your opinions and the results of this first observational study to design STOP-2. STOP-2 was a randomized controlled trial conducted between 2016 to early 2020, right before the pandemic hit. And the goal was to evaluate the efficacy, so how well does it work, and the safety of different durations of IV antibiotics for treatment of exacerbations. We included adults only in this trial because we wanted to ensure that it was safe before we started treating children similarly. Participants could be at home or in the hospital, and we provided a standardized antibiotic guideline. So pharmacists across the nation helped put this together, and it was the same dosing and frequency so that participants were being treated very similarly. So Sonia Helchi, she's our biostatistician in the STOP group, came up with this brilliant design, and we call it the Sonia. Sorry, Sonia. Participants were enrolled at the beginning of the study. On day 1, we collected lung function and symptom scores. But this is what was brilliant. They weren't randomized until visit 2, so day 7 to 10 into their antibiotic therapy. We again measured that lung function and symptom scores. And we separated participants into 2 different groups based on their improvement in lung function and symptom scores. If they improved by 8% or more in lung function as measured by FEV1, percent predicted, and then had an improvement in symptoms, we said, hey, that's a large improvement. Others that didn't meet that mark, we said, okay, you had a smaller improvement. For those that had the larger improvement, we said, you know what, they probably don't need a longer duration of IV antibiotic therapy. We randomized those participants to receive 10 days of IV antibiotics or 14. For those that had the smaller improvement, we said, hey, they may need longer duration of IV antibiotics. We randomized those participants to receive 14 or 21 days of IV antibiotic therapy. Each group had their follow-up visit 14 days later. So let's look at what happened to lung function in those that had the large improvement early on. On the x-axis, you have days from the start of IV antibiotic therapy, and on the y-axis, you have mean lung function improvement. Here's our 14-day arm, improvement by 13.4% by the end of the study. Here's our 10-day arm, 12.8% improvement. There's no statistically or clinically significant difference between these 2 groups. And I can tell you that the symptoms also improved, weight also improved, exactly the same. This was great news. We just proved that 10 days was just as good as 14. So what about that smaller improvement? This tended to be our participants with lower lung function, FEV1 40, 50% or so. Their improvement in the 14-day arm was about 3%. Anyone want to guess what the 21-day arm showed? Exactly the same. Symptoms and weight also improved exactly the same. So here we showed 21 days was not better than 14 and did not provide extra benefit. This was great news to us because we could potentially avoid toxicity and side effects of antibiotics given for a longer period of time. And again, you as a CF community really showed up for us. This clinical trial was almost 1,000 participants in 59 sites in the US and Canada. I see many friendly faces. Yes, we can see your faces from up here. I was told I wasn't, but I can. And you all recruited for this clinical study, and many participants, patients that are listening online did as well. It is because of all of you that we got to answer such an important question. Knowing that we can improve lung function and symptoms by using less days of IV antibiotics is such an important outcome. We believe, based on this data, that treating for longer than 14 days doesn't actually improve lung function or symptoms. And in general, this practice should work. However, there may be instances where a person with CF may need longer than 14 days of IV antibiotics, and that's certainly a decision between the patient and the treatment team. So where are we now? This is a graph from the CF Foundation Patient Registry. On the x-axis, you have years from 2007 to 2022. And on the y-axis, you have the percentage of individuals who had at least one exacerbation treated with IV antibiotics. It's important to note that both STOP and STOP-2 were conducted before ETI was widely available. Some of our participants may have been on other modulators, but many were not. This is where ETI was approved. And we know from the clinical trial that exacerbations were decreased by 65%. And here's where the COVID-19 pandemic hit, and exacerbations were decreased even further, likely due to social distancing and use of masks. So we can see in the US that ETIs made exacerbations less common, but they have not gone away. Not for people on ETI, and certainly not for people not eligible for ETI. Other parts of the world have unfortunately not seen the reduction in exacerbations yet, but hopefully that is coming. We know not everyone is eligible for ETI, so the knowledge that we have gained from both STOP and STOP-2 is very important for all people with CF. Our goal is to keep pushing on and answering more and more questions. So we again surveyed you all. What's the next important question that you wanted us to answer next? We had a winner. You all wanted to know, do we really need 2 antibiotics to treat pseudomonal infections? And we started to design the next clinical trial. 1 versus 2 IV antibiotics for treatment of Pseudomonas. As we were designing this clinical trial, though, we're like, hey, we're doing the same thing over and over again. And we quickly realized that we could use the same protocol to ask multiple questions in exacerbations. So we created the STOP 360 platform that just keeps going and going and going. So the first clinical trial that we'll be conducting on this platform is the aminoglycoside study. We want to evaluate the safety and efficacy of antibiotic regimens with and without IV antibiotics. Why are we trialing 1 versus 2? So current CF exacerbation guidelines suggest that Pseudomonas airway infection be treated with 2 anti-pseudomonal agents. Luke just showed you that Pseudomonas is one of the most common bacteria that infects our patients with CF. Commonly, there's 2 classes that normally we choose. One is aminoglycoside, and the most common antibiotic is tobramycin. Another class that's usually used is beta-lactams, something like ceftazidime, cefepime, and other antibiotics. However, the objective evidence for this is lacking. And we know there's a toxicity associated with antibiotics, particularly tobramycin. Any person with CF who's had a bit of tobramycin in their lives will tell you they may have ear ringing, a sense of being off balance, have vertigo, some even have hearing loss. This question has never been studied in a large clinical trial. We know that the CF community is willing to participate in large clinical trials. And this is yet indeed another priority of the James Lind Alliance that Dr. Hoffman introduced. And this clinical trial hits on two of those priorities. Which antibiotic combinations and dosing plans is best? And is there a way of reducing negative effects? All right, so you're saying, Natalie, you just told me there was 1,000 participants in STOP-2. Well, get on with it. Tell me what that showed. So here, on the x-axis is study visit. As a reminder, the study visit 2 is when IV antibiotics were complete. Study visit 3 was follow-up. On the y-axis, you have mean FEV1, so lung function. Here's what happened if those participants were treated with 1 anti-pseudomonal class, that's the improvement in lung function, 2 in blue, and 3 in yellow. There's no difference in whether we use 1, 2, or 3, which gives us even more evidence that this trial should be conducted. Can we get away with less antibiotics, less toxicity, and still have the same improvements in lung function and symptoms? So the aminoglycoside study is a randomized controlled trial. We will use 14 days of duration because we've just proved that that works best. Adults and then children 6 and up can enroll. Participants can be at home or in the hospital. We will use that same antibiotic treatment guidelines, and participants can be on or off ETI. So important to note, our STOP program has worked very hard to make sure all of these studies are safe for our patients to enroll. We need your continued help in answering this important question. So in blue is our projected site approval. We all know how long it takes to get sites up and running to run these large clinical trials. And here in yellow is actual. Most months we were ahead of target. We expect to enroll 730 participants. In the first couple of months already on rolling, we are already ahead of target. Yes, thank you. That's to all of you guys. We are currently working with CF centers in Europe so we can expand enrollment overseas. So we know that ETI has improved health. We want to try to lessen the burden and toxicity of IV antibiotics. We want to treat people with CF in the best way, not in the most intense way. So the aminoglycoside study is set to run until 2027. We are already thinking about what the next question is. Where should we treat? More and more people with CF are telling us, we don't want to be in the hospital. Do we blame them? Nick told you that he spends 1/3 of his year in the hospital. So when we looked back at STOP-2, again, almost 1,000 participants, we saw that those that spent some time, any time in the hospital, had better improvements in lung function and symptoms than those that were treated entirely at home. So how can we make treatment with IV antibiotics at home as good as in the hospital? Can we incorporate all the support that we have in the hospital? Can we use telehealth that we learned so much about during the pandemic? And this is yet another priority of the James Lind Alliance, home versus hospital. So Dr. Chris Goss and I actually did focus groups of CF providers as well as people with CF and their families, and we gathered your opinions. What stuck out to both of us was why home was better and why we needed to do this work. And here are a few quotes. The mental aspect of it is so big. Being locked in the hospital for 2 weeks is so depressing. Stopping your life for something you could be doing at home. The financial aspect is huge. It really depends on your employer and what their benefits are. My current employer does not cover when I'm out. This is very detrimental. This participant actually shared that her previous job had actually covered her salary when she was out, but not her current employer. For me, there's nothing like being at home and having access to whatever you want, whenever you want. My dogs have kept me uplifted. We all love our furry friends, for sure. I have control over my schedule. I do not recover well in the hospital, being woken up so often. And I think we can all understand the importance of sleep. Since STOP-2 only included adults, Margaret Rosenfeld and D.B. Sanders conducted a pilot study in our younger people with CF. Their goal was to assess the feasibility of a future larger randomized controlled study looking at the intensity of antibiotic use in outpatient exacerbations. They enrolled participants 6 to 18, lung function 50% or higher, with one exacerbation in the previous year. Enrollment occurred when they were at baseline and healthy, and they planned 120 participants. These participants were instructed to call the clinic if they had increased symptoms. They were evaluated over the phone or in clinic. If they were felt to be too sick, they were treated outside the trial. But if their symptoms were acceptable, they were randomized to either one, tailored therapy, which meant increased airway clearance with their vest, their acapella, pulmozyme, hypertonic saline, and using antibiotics only if necessary, versus immediate antibiotics, and then a final study visit. For every clinical trial, there is a data safety monitoring committee who pauses clinical trials every so often to assess the safety and make sure it's okay to continue. This study was actually stopped early for a good reason. One, it was feasible. After 63 patients that completed the study, they saw that parents and children were completely willing to be randomized to either side. But what was great was the tailored therapy avoided antibiotics in 70% of participants. So they are currently planning a larger clinical trial that will start next year. Switching gears just a bit, we know that females with CF have worse outcomes, particularly shortened survival. What we wanted to know is, hey, could exacerbations have anything to do with that? Our group at Johns Hopkins, led by Christina Montemayor and Kevin Pasoter, analyzed the CF Foundation patient registry from 2010 to 2019. Here on the x-axis is age in years, and on the y-axis is the annual number of exacerbations. Males are shown in blue, females are shown in red. And you can see, starting at puberty, there was a higher number of exacerbations than males. This actually replicated data that was shown a few decades ago. There are a few theories as to why this could be. One reason could be due to estrogen. Chochermal and colleagues showed in 2012 that estrogen was associated with pulmonary exacerbations. Melanie Holtrop and Roxa Jane more recently showed that estrogen levels are highest during ovulation in females with CF. And at the same time, lung function is at its lowest. What's not shown here is that symptoms are at its worst, and a whole host of inflammatory markers that they measured showed that those inflammatory markers were at their highest. And if you see on the right side of both of these graphs, oral contraceptives, something that controls the estrogen. When females are taking those, estrogen is at its lowest, and the trends are completely reversed. Lung function is at its highest, symptoms and inflammatory markers are at their lowest. And there's more research ongoing. So will infections have the same implications in the era of ETI? Lisa Saman and Whitney Brown are currently leading the International Clinical Guidelines Group, and they're updating how we diagnose infections from respiratory tract samples. We may need two sets of guidelines, one for those eligible in taking ETI, and one for those that are not eligible for ETI. We may need different strategies for different groups. You just heard from Nick, who was not eligible for ETI, and he told you he spends a considerable amount of time of his year in the hospital. Mariah was featured in our plenary 2 years ago, who is taking ETI and doing wonderful and doing things she was not able to do before. Becky was featured in our plenary last year, and she is certainly grateful to have ETI, but she's really having significant health issues still. The CF Foundation remains committed, and I'm excited to share some early days of clinical trials ongoing. I think many of us in this room are used to seeing this one, right? The pipeline of drugs developed to fix the CF protein. And the top 4 rows are what's available to our patients now. Look at our anti-infective pipeline. We have a lot going on. The top 5 rows show antibiotics that are available to our people with CF. We have many other clinical trials ongoing, and I would like to highlight 2 that involve bacteriophage therapies. So what is a bacteriophage? These are naturally occurring in our environment that kill bacteria. They are typically not harmful to the person or the host. They're only harmful to the bacteria that they aim to kill. We have targeted therapy, which they bind only to bacterial strains and not other cells in the body. Bacteriophages can be used as an alternative or in addition to antibiotic therapy for specific bacteria. So the phage actually locates the target and attaches using tail fibers. Then it inserts the DNA into the bacteria and starts making copies of itself. The bacteria is killed and releases many more copies for the bacteriophage to then find, infect, and kill more bacteria. Here are all the bacteria that currently have bacteriophage studies ongoing. You heard Melanie say to the Senate, it is inevitable that more Americans will encounter resistant infections. It's not a question of if you can catch them, it's a question of when. We need more tools. We're going to concentrate on Pseudomonas today. You heard from Nick. Pseudomonas creates havoc for me and plays a part in every facet of my life. More and more antibiotics are not working for me. The bug is resistant. Nick needs more tools. So Armata just completed a phase 2A clinical trial called SWARM-PA. PA stands for Pseudomonas. The safety was assessed at multiple time points. They started with a single dose first, gradually increasing the dose, then going to twice-a-day dosing for 5 days, and finally ending up for twice-a-day dosing for 10 days. And I think this graph is actually really fascinating. If you look on the x-axis, there are trough levels. As you go to the right, that means a higher level of phage was found in the sputum. Pseudomonas levels are on the y-axis. The higher you go on that axis, the higher levels of Pseudomonas are found. So look at this group. People that had the highest level of bacteriophage found in their sputum had the highest reduction in Pseudomonas compared to baseline. This phage was well tolerated, there was no adverse events, and there was no emerging resistance. So next steps for Armata, they are currently evaluating the same phage in a larger population that is similar to CF, the non-CF bronchiectasis population. And the study is called Tailwind, and they're dosing at home using that twice-a-day dosing. And pending these results, they're tentatively planning for a larger study in CF. BiomX is completing another bacteriophage study, and they are assessing the safety and tolerability. They enroll participants that were already on inhaled tobramycin, calicineris-treonam. They did a phase low dose daily, a phage higher dose daily, and then moved on to twice a day, and then follow up for 6 months. And again, this was well tolerated. There were no adverse events. The 7 that received phage therapy in blue had a reduction in Pseudomonas at day 15. There was also no emerging resistance. And currently, they are on part 2 of the study, which is larger, 24 patients using the high dose twice a day for longer, 10 days. These results are actually expected this month. It's the 5-year anniversary of the Infection Research Initiative, in which the CF Foundation dedicated $100 million. with a goal to advance research into infections and improve outcomes. CF infections are a worldwide problem. This work cannot be done alone. It's a global effort. Here are numerous efforts that are across the globe to understand and find best treatment. These include clinical trials and collaborations. This is the way we get drugs approved. This audience is critical to making this happen. We can't do it alone. You in the audience are international collaborators, people with CF who participate in research. This is how we get it done. And I want to quote Nick, "I don't do it for the me, I do it for the we."
For those of you who are struggling with new or old infections, we see you, and we're committed to finding therapies that work for you.
Luke and I, in the whole CF care and research community, would like to remind all people with CF that you have a worldwide team committed to this work. Now I'd like to ask the audience, everyone stand up. All right, and what we're gonna do, Luke's gonna count to 3, and then you're going to read the words on this line. We're gonna shout it. We get one chance at this. Until it's done, go ahead, Luke.
1, 2, 3. Until it's done.
Awesome, guys. Thank you very
Thank you.
much.